Hi everyone, welcome to researchmd.com. Another great presentation today. Today we're going to talk about a most common condition right now is what, like plantar fasciitis. Okay, again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and the residents, and I'm a director of research, also assistant professor of medicine and two major medical schools. So let's get into our subject. So what is plantar fasciitis? First, anything we have to look at the definition, right? What is the definition of plantar fasciitis, right? It's an inflammation of thick band of tissue, which is called a plantar fascia, that run across the bottom of each foot that connects the heel bone to the toes. Okay, first we need to know we got a nice picture over here, where the plantar fascia is. So it's an inflammation of the plantar fascia. Fasciitis, anytime itis means inflammation. One of the most common cause of the heel pain. Okay, epidemiology, let's look at the facts. 1 million patient visit per year to the doctor due to the plantar fasciitis. Most common cause of heel pain. Lifetime incidence is like 10%. Average, again, 40 to 60. More common in females than males. Okay. So what is the pathophysiology? How does this develop plantar fasciitis? It's a degenerative process. What happened, you got the repetitive stressing or the stretching of the plantar fascia, right? That kind of lead to micro tears and damage. Most because, standing for a long time, or you got a lot of body has to wear a lot of weight, okay? The constant stretching of the plantar fascia results in chronic degeneration of the fascia, eventually leading to pain during sleep or at rest. So what are the risk factors? Anything, if we get older, risk is higher, right? Same thing over here. When the age usually between 40 to 60, when the patient is like obese, if the body mass index is greater than 27, we need to be careful. Intrinsic foot and calf muscle tenderness. And there's certain type of exercise we have to be careful that kind of lead to. Studies have shown that, like if you're a long distance runner, you're a ballet dancer, and if you do like aerobic exercise, or aerobic dance. And the foot mechanics, some people are born with some congenital disorders of the foot, like the flat feet, high arch, or even atypical pattern of walking also can be due. We talk about the occupation, like factory workers who stand on the foot for a long time, teachers. Stand on like a hard surface are more at risk for developing this, okay? So what are the signs and symptoms? The first thing, heel pain with first step in the morning. When you get up in the morning and you take that first step, you feel the pain, okay? Or you can, after a long period of non-weight bearing, you can have the pain in the foot, right? Tenderness to the anterior medial heel. Limited dorsiflexion of the tight Achilles tendon. A limb may be present or may have a preference when you're toe walking. Pain usually worse when barefoot on hard surface and with the stairs climbing. Okay, pain usually get worse when you're on barefoot on hard surface when you climb the stairs. So how do you diagnose this? One of those diagnoses, you take the exam, you take the history, you take the examination, you come up with the clinical diagnosis. That's the most important thing into that. Classic presentation. You get up from the bed, you take the first step, you start feeling the heel pain. So pain begin with ambulation after a period of inactivity, then it will improve with resolve after a long time of activity, the pain can go down. Pain reproduced by palpating the plantar medial calcaneal tubercle. That's at the site of the plantar fascial insertion at the heel bone. So it's around, if it's the foot, if you're looking at the bottom, so if you palpate on this area, on the bottom, you're going to feel pain. Okay, there's something called a WINDLASS test, which we'll talk about. That's a passive dorsiflexion of the foot and toe, then you will feel the pain. And the imaging studies, we talk about radiograph, ultrasonogram, and MRI. So this is the WINDLASS test, right? If you look at it, you're doing the passive dorsiflexion of the foot and toe. You bring again dorsiflexion, okay? You feel pain. And look at the sensitivity and specificity. Sensitivity is 32%, specificity is like 100%. That means, when you have like a very high specific, if you have this test positive, you can say your patient has plantar fasciitis. Now, let's do some x-rays. What are the sensitivity and specificity? It's pretty good. On lateral, yet when you order the x-ray, you have to do the lateral plain radiograph, okay, to pick this up. You look at the thickness of the plantar fascia, measuring 4 to 5 millimeter. Within 5 millimeters, calcaneal attachment is visible, and that represents a reliable sign for plantar fasciitis. Again, let's bring in the number. How good is this X-ray? Sensitivity is 85%, specificity 94%. So anytime you have a test that high, it's a pretty good test, right? Let's look at the next test is available. It's an ultrasound. That is the plantar fascia show fibrillar pattern due to the hyperechoic appearance. That's what you have to look at for hyperechoic appearance. So type 1 collagen fiber bundle embedded within a background of hyperechoic matrix. And you look at the thickness of the over 4 millimeter perifascial collection, calcification within the plantar fascia. And again, when you look at the sensitivity and specificity, is like sensitivity is 80% and the specificity is almost like 89%. Okay. Again, then you have an MRI you can do. If you look at the X-ray and ultrasound, you want a very extremely good test, you can do for an MRI. But most of the cases you don't need it. But we're just going to talk about what will you find in the MRI. Thickening of the plantar fascia, most commonly at the calcaneal origin, intrasubstance area of intermediate signal on T1 weighted sequences, increased signal on the fluid sensitive sequence, edema in the adjacent soft tissue. These are the MRI finding. But the most of the time, all your diagnosed based on the clinical finding and then other finding. You don't have to reach this expensive test. Remember that. So how do you treat plantar fasciitis, right? Always try the conservative measures first for maybe 6 to 12 months and see if it is any improvement before you're thinking about surgery. Relative rest from offending activity as guided by the level of pain, right? And ice after activity, maybe taking some topical NSAID if you don't have any renal problem or anything. Deep friction massages you can do at the arch and the insertion. And then always there's shoe inserts or orthotic you can buy. You can wear nice splint, nighttime splint also help. And there's a lot of proper stretching of the muscles, okay, like a proper stretching of plantar fascia, Achilles tendon, gastrocnemius, and the soleus muscle. We'll make another presentation about this exercise. So all of this, the conservative measures didn't work. Then you have to more advanced treatments. One is called extracorporeal shockwave therapy. Then you have botulinum toxin and steroid injection. Steroid injection, again, you may get benefit for like 3 to 6 months. You may have to repeat the injection again. Okay. Surgery, always remember the last option in plantar fasciitis. Thank you so much for watching today. Please subscribe to our channel. Thank you.